So let's get straight to our next session. It's aptly titled, Hitting the High Notes of Patient Engagement and Adoption. Is anybody planning to sing? We are in Nashville. So we've got a great panel of telehealth leaders from MUSC, from Tallahassee Memorial Health, and from the Mayo Clinic. And I'm very happy to welcome Kate McCarthy, Senior Analyst with Forrester Research, to lead the panel. So take it away, Kate.
Thanks so much. Hi, everyone. I wish I could still get a high E, because that would just be funny, I think, to get this started. But aptly titled, Hitting the High Notes of Patient Engagement and Adoption. Really exciting panel for you. And I want to just open it with a few ideas for you all to think about. Looking around the room, I think most of you all have been in the industry at least as long as I have, and you remember that moment in 1996 when we started seeing more volume in outpatient services than we had in inpatient care. How many people remember that? Yeah. And it was a huge culture shift for our hospitals, right? We built everything around bricks and mortar with inpatient buildings and OR suites that made it easy to get to and from the floors where we might put patients when they're recovering from surgery. Well, now we can send people home same day from, bilateral total joint replacements. I never thought I would see that day, but that day is here. And now we're starting to talk about the future of healthcare shifting not just to outpatient, and we've seen huge rises in usage of retail and urgent care, and so new sites of care that further disrupt our bricks and mortar culture. We expect that in the next 5 to 10 years, virtual care will do to outpatient care what outpatient care did to inpatient care. So most care will be delivered virtually. This is better told with my service dog on stage with me, and she's getting a day off today. But I'm a rare disease patient. I'm high risk. I have Addison's disease. I obviously travel for my work quite a bit. And most of my care, because of the nature of my work and because of the nature of my disease, is actually virtual already today. I use an Apple Watch. I've got all sorts of cool gadgets. When I'm home, I have a smart home that connects to a healthcare ecosystem as well. So I'm living proof that you can actually take patients and engage them and give them better care with digital. And for folks, looking at the future of healthcare and wondering how we're going to improve on cost and quality outcomes and not just solve for patient engagement as one of the gateways to doing that, digital is a $300 billion opportunity in our industry. Virtual care is about embracing digital as a primary way to engage our customers, whether it's a patient, whether it's a physician in a hospital we're working with remotely. It is where healthcare is going. And so I'm really excited to be here with you today. I want to introduce our panelists. We have Steve Sponsel from Mayo, Lauren Faison from Tallahassee Memorial, and Michael Hasker from MUSC. I want to give each of them a moment to introduce themselves, and then we're going to get started. And I encourage questions as we get toward the end of some of our initial questions. This should be interactive, and I want to hear from you all, because there's all of this expertise on stage for you. Take advantage. Steve.
I am Steve Sponsel. Great to be here this morning. I'm from Mayo Clinic. I've been there for over 30 years now, so through a lot of these transitions. We are a large multi-specialty group practice, and we are in 3 states. I'm based in Rochester, Minnesota. We have facilities in Arizona and Florida as well. It is a nonprofit foundation with a really strong message around the needs of the patient come first. My role, I'm a director in media support services. We support a variety of media platforms, including video. My personal background is in graphic design and in workflow analysis, kind of a strange mix, but it's been very fun. Thinking about transitions, I started out as a little kid helping manage the paper medical record, and I've been through the whole transition, so by being part of the design of our EHR and getting involved in an Epic implementation right now. So my primary role is coordinating our media platforms to support the clinical practice. Some of the things we've worked on, we've done the neonatology program Iran mentioned earlier, makes me cry every time I think about that or see that video. We've done virtual consults. We've worked with Vidyo and SBR. See Chris in the front row up here. We're doing e-tumor board case conferences using some video technology that connects oncologists and pathologists in our organization with distant medical sites that are looking for advice and referral. We are using the EICU product from Philips, and our most exciting new project that we're exploring is inpatient digital engagement through the patient TV system in the hospital room.
Terrific. Lauren.
Good morning. My name is Lauren Faison, and I am from the big town of Tallahassee, Florida. And being that I have zero musical talent, this will be the only time I share a stage with a Grammy winner, so my kids are going to be super excited when I call them tonight. But in Florida, we're very glad that it's almost the end of hurricane season, as well as for you college football fans, college football, because my Seminoles have not had a good season. But anyhow, my disclaimer is I am not a clinician, I am not a techie, I am somewhere in between. My job is to be a customer advocate at our hospital, and that is those customers being my colleagues, our employed and contracted physicians, our bottom line, but most importantly, of course, our patients. That is my role. I'm in the business side of our operation. We are a one hospital system, if you will. We are a nonprofit community hospital. We get zero tax dollars or incentives. So what comes in the door, we have to live on. And we are doing very well at that. We serve an 18-county region in South Georgia and North Florida, and we have a lot of challenges in doing that. We're the only level 2 trauma center in the entire area of that 18 counties. We stay on red. We have a lot of full beds, very crowded ERs. We built a freestanding ER to try to take some of that load off the hospital ER, and all we did was increase our capacity, and we are seeing more patients than ever. So telehealth was a natural evolution for us. I will tell you I have a different background than probably my colleagues on the stage, in that I come from the nonprofit world. So I grew up in nonprofit administration where we know how to move mountains on a nickel. So 5 years ago, when I made the transition to healthcare administration, the sticker shock was amazing. When I saw the amount of money that is spent in the day-to-day operations of our little hospital and the amount of inefficiencies, it became an opportunity. All I saw was tons of opportunity. And I remember the second day on the job, I was shown to a room where there was 3 big carts that the Department of Health in Florida had given to help connect our trauma systems, these big telemedicine carts, and they said, figure it out. Right before I started, I was Googling what telemedicine was. 6 months later, I was standing on the floor of our Senate at the legislative session doing a live demo of how telemedicine works and all the advantages and efficiencies before our Senate president. When I got beyond not getting sick to my stomach in front of him, it's hard not to get passionate about this technology. And even in our small system, I have major budget envy of many of the presenters already this morning and probably my colleagues. I spend about $40,000 a year on our telemedicine program, and most of it goes to video, but that's great because it's all from my software fees and it keeps us working, so we love video. But we've really had to figure out how to do it very efficiently because in Florida we do not have good telemedicine legislation. We do not have parity laws. There's very little reimbursement. It's very challenging. So what we have really used and implemented telemedicine for is looking at cost avoidance and looking at transitional care. And how do we, even within our system, make us more efficient? They literally enable physicians to be 2 places at once. When I tell them that, it gets their attention. And so my job is, I am the telemedicine department of TMH. My IT department has learned to accept me. They don't love me yet, but they will. We actually had an empty room that wasn't being used, and I wrote telemedicine command center on it on paper, and I was convinced that if I have the idea, if you build it, they will come. And they eventually have let me have a little desk in there, and I sort of float in and out. But we were so challenged, and technology in healthcare is challenging. It's the security nightmares, the HIPAA, all of those implications are very scary for our IT department. So I understand why those guys are very stressed, and gals, I get it. So we actually developed a third party, and because we knew if we didn't, we'd still be talking about telemedicine 6 years from now, and all the reasons we shouldn't do it and how dangerous it is. We had it up and running in a week. And now we have it across about 6 different specialties, and we're doing a lot of direct-to-patient as part of our transitional care. Again, we're not able to bill for most of it, but it's keeping people out of the hospital, so that $40,000 investment is saving upwards of $1 million a year in cost avoidance, which for us is a big deal. But most importantly, it's improved our patient satisfaction, their engagement. I love this topic because there's no better way to engage people than to look them in the face when you're talking to them, no matter where they are. They're 2.5 hours away and they can't get there because they can't beg, borrow, and steal to pay somebody gas money to drive them to you. Why would we do that with a click of a button? We can see them. So I'm excited to share with you some of the things that we are doing and appreciate the opportunity to be here.
Thank you. Michael.
Good morning, everybody. My name is Michael Hashker, and I represent the technology side of telehealth for the Medical University of South Carolina. I started in 2007. I was a former network systems manager for MUSC when 2 very bright physicians came to me with ideas on how to impact their patient communities. One of those physicians was Dr. James McElligott, who is now the director of the medical director for telehealth for the South Carolina Telehealth Alliance and MUSC. And the other physician was Dr. Donna Johnson, who started a maternal fetal medicine program in MUSC. And through their programs, Donna, 3 years later, documented a lower infant mortality rate because of her program in telemedicine. That kind of started my passion. I made a career shift into telehealth services. And in 2013, MUSC formalized the Center for Telehealth with an effort to deploy telehealth across all the integrated clinical service lines. Again, we're in a very rural state in South Carolina, a very poor state. Giving access to patients is my passion. We're fortunate in that we have a large, very well-developed private healthcare network called the Palmetto State Providers Network, which was built with a grant from the FDA and rural connectivity funding. And through that network, we're able to connect rural providers and get the access to the patients most in need.
Terrific. Now, for members of the audience, how many of you have telehealth programs up and running today? Awesome, hands down. How many of you are thinking about investing sometime in the next 12 months? Oh, I want to see some hands now. All right, we'll work on you. Steve, talk to me a little bit about, stepping back a minute, some of the barriers to patient engagement you all have had at the Mayo Clinic.
Well, I think one of the most interesting things looking at where we've been, you touched on it with the that flip from inpatient to outpatient. We've always been outpatient. 90% of our business is outpatient practice, but we have been very destination focused. We specialize. We have really excelled at brick and mortar. I work in a 1920s vintage clinical building that housed 400 physicians. The building was literally built around the practice, patient flow, medical record flow. Even the arrangement of the specialties inside of the building was built on how the record needs to traverse the building. So we're fantastic at that. It all has to be rebuilt. And I think the other really interesting thing there is that the patients understand the experience very, very well, brick and mortar, and they don't. So we don't understand it. They don't understand it. Trying to rebuild a connection using enough of the features of the traditional model and enough of the new to hit the right balance that it's compelling, but it feels familiar.
Yeah, for sure. Michael, how about you all? What are the big challenges you've seen in patient engagement as you've started to make these transitions?
So the challenges from our perspective are access. Again, as a rural state, affording everybody access to health care is a right to me. So getting relationships with those primary care docs in the rural communities, getting them connected, providing the equipment and the technological services that they don't have, the IT support that they need, and then access to the specialists in the urban centers in South Carolina. We have 3 large cities, Greenville, Columbia, and Charleston, and that is where I'd say 80% of the healthcare specialists exist in our state. And we know that as an academic medical center, when you train medical students and they graduate, you know, they're not itching to go to small town South Carolina and practice.
Right.
They want to practice in urban centers, and they want to get the experience that urban centers offers them. I think telehealth is a way to, you know, give them that experience, but have them provide for patients in rural settings.
Yep, for sure. And Lauren, what would you add?
I think we suffer many of the same challenges. It's hard to recruit to places like Tallahassee, even as a bigger city, but even to give people those access points. I always described it, and again, I've been in this for 5 years, so I'm still in my infancy,
Right.
but we do a great job when people come through our doors of fixing them and helping them, but how we bring them into the system and what we do as they transition out of the system to their post-acute facility or home or wherever, there's huge opportunities to do it better. When the chips are down and you need something in an emergency, we're going to do it right. But how we engage you in managing your own health proactively through wellness activities, which is kind of also falls under my purview, as well as what we do with you once you leave our hospital. Do we make sure you get your medications? Do we make sure that you get those follow-up visits, or do we just get you out and, you know, good luck, you're on your own? And so we've really used technology as a means to kind of do those virtual handoffs, both with the patients and with their, you know, pre and post care providers, and really giving them a way to engage. I think many times patients don't know the questions to ask, or if they don't have resources, they don't know how to get those things. And so we've been using the technology a lot, particularly in that transitional care piece, to reach out to people once they're home. How are you feeling? Did you get your medication? Let's do a virtual e-pharmacy visit. Show me your medications. What are what are the blue pills? What are the pink pills? What are the white pills? When are you taking them? Giving away a comfortable, safe way for them to engage with all types of our providers at our facility. And they just didn't have a means to do that before.
Yeah, absolutely. For you all in the audience, how many of you recognize culture change as one of the biggest challenges in making this transition? Show of hands. Yeah, I think that's pretty common. It is not just culture change for our bricks and mortar culture, as we talked about, but as Steve pointed out, a culture change for our patients. And we're shifting what they can expect from us as we start to engage with technology. One of the things I've worked with a couple of providers on myself over the years is how do you get people to engage with you not just on their health, but on their wellness and on the social behaviors that influence disease outcomes. And I think as you were just talking about, both of you, especially in your rural communities, this is serving as an access point to people who would have social limitations to getting to your care settings. For you at Mayo, familiar to my background at MGH, as the big AMC, it also gives folks in rural communities access to your amazing talent. And it gives patients some removal of geographic barriers so that they can get to that next level of care if they need it. So the nice thing about our panel today is that diverse set of experiences you all are bringing to the table, and I'm sure as you've executed, there have been a number of challenges that you've faced in implementation. So Michael, I'm going to start with you. Would you mind telling us a little bit about what challenges you've had, either technologically or otherwise, as you've implemented your very successful program?
So I think one of the major challenges that we face, and MUSC has created a very extensive training program around that, is to understand, we call it diversity and inclusion, to understand the cultural, religious, ethnic, and socioeconomic differences amongst the people in our state. This is very important in how you communicate a healthcare plan to people, and how they understand what you're communicating. And our staff goes through extensive training to deal with different cultures, different religions, different ethnic groups, and how to communicate with those groups in their care.
Great.
And I think I was thinking about culture. I was thinking about my professional culture within the walls of our system has been challenging because everybody's so busy, everybody's running around. I don't have time to deal with your project. I'm taking care of patients. and really forcing the message of telehealth and telemedicine solutions should be a tool in everybody's tool belt, no matter what your specialty, no matter what the services you're providing. It's not Lauren's project over here, which is, I had to fight that battle. It's not this whole nother system of healthcare. It's doing what you do every way, but instead of going into an exam room, you're going to a computer to see that patient. Everything else can stay the same. I'm not, this is not a whole new system of you providing your care. And I think having to say it over and over. I'm known as the telemedicine cheerleader, which is a little offensive because I'm not a cheerleader. But because I have to do it. I mean, sometimes you say it to them 10 times, they go, well, where's this technology been? And I'm like, I've been telling you about it for 3 years. But it has to wait till the right time. It has to fit a need immediately. And so I constantly keep going around showing them, this is what it can do. Now think about your biggest challenges. Is this a right fit? Because it's not always the right fit, but for many instances it is. If there's budget constraints, well, what are we spending the money on? Is there a way to solve that problem virtually? For our rehab unit across the street, literally, if you have a good arm, you can hit our hospital with a baseball. We were transferring people back and forth across the street for follow-up appointments, orthopedic follow-up appointments after surgery, was costing us $110 to drive them across the street. Not to mention you're getting somebody out of bed, you're putting them on a van, you're driving them up, putting the orthopedic office on the 7th floor, which is always a good idea for somebody who's had a hip replacement. And so we said, well, why are we doing this? So I had to go talk to our orthopedic group, which is not employed by us, but they're our big partner, and I had to show them how this works. Well, now they're doing all those visits virtually. And the patient's getting better care, because now the nurse who takes care of me all day is part of that surgical follow-up. I see the surgeon. I mean, some of our elderly patients are great. The ladies will say, well, I need to put lipstick on before I see them, and because there he is on the screen. And they love it, because now I'm still in my bed. The people who are taking care of me all day can help me articulate my challenges and what's going on with my care. I can hold the webcam up. They can see my knee. They can look at my sutures. And so for the patient engagement piece, that's easy. It's an easy sell for the patients. Yeah. It's getting the providers and the nurse who doesn't want to see herself on the screen, getting her comfortable with hitting the 2 buttons to make the connection. It's really, you have to engage everybody for both ends, but the patient to me is the easiest sell.
We have a unique challenge, I think, that we've opened up some new space. I mentioned that we're looking at this really kind of an experiment to see how we can use the patient entertainment system to introduce more digital interactions, two-way interactions. We've been partnering with Vidyo on this. We have a mobile application and a portal presence that we're really quite proud of, but it's still only about half of our patients use the portal or use the mobile app. And that's a self-selected audience. So, we are a self-selected audience. Everybody in this room has invested a lot of this. We love what we're doing. Our patients that sign up for the portal really want it. And I know, looking at the portal literature, parents of chronically ill children are the #1 users of portal. Other chronically ill adults are the second ones. But we're a destination center. We have kind of a short-term interaction. So the engagement is a little bit different. When we're looking at the hospital setting, it's literally a captive audience. So we are looking at the interactions with everyone, not just the people who are self-selecting in. And what we found is that there's a huge age divide. We have a patient audience that's the patient, I think, in Rochester is around 73. Our Arizona and Florida facility, it's even higher. We're seeing a dividing line at about 40. We deployed a new streaming TV system that will allow us all of these interactive features in our Wisconsin facility in a birthing unit with 20-something mothers who love the new system. It looks like Netflix, and they totally get it. We also deployed in our St. Mary's Hospital in Rochester with a very high age audience. We're in a intense cardiac unit, and basically the almost verbatim response from our patients is, "Where the hell are my channels? You broke my TV." And so we clearly have missed something there, and we've got to figure out how to simplify and how to really think about it from the patient's perspective. And we talked a little bit earlier in the earlier presentations, and we need to start with people. We're patient focused. We need to understand the patient needs, the provider needs, move on to what those processes are, and then deploy the technology. We got like everyone else, we get really excited about our new toy, and it just doesn't resonate with everyone. And unfortunately, it doesn't resonate with the people who need it the most.
Yeah, and that can be a real challenge. I think the really interesting thing about what you all just said, though, is in fairness, I've been sitting in this seat for a long time, and usually when I throw out that question, I get something back about, my physicians aren't over the Epic install, they don't want to use new technology, we can't get it to interface, all sorts of technical challenges, and no one said that. Like, you're working on making a better UI so you get better engagement, but no one.
We've started saying for every one of these engagements we're looking at, 10% of the problem is technical and 90% of it is the cultural, is the workflow, and
Well, I think
needs
that's
a lot
where
of
the fault
attention.
of many programs are. They see it as a technology project.
Right.
And it's really not, and I always resonate the same message. Technology is easy, but if you don't plan how to embed it within your workflow, you will fail. And then people say, oh, it didn't work. Telemedicine didn't work. It was a waste of money. It's not that, and it can't be owned by IT. It has to be owned from your C-suite people to your physician champions to the nurses. To me, the nurses are the one. They're the key to success and getting. You got to have the physicians willing to see them, but a lot of them don't want to be bothered with, even though it's 2 buttons to click, they don't want to be bothered with that sort of thing. So if you can have the nurses that shove it in their face, and then they'll actually use it, that's where the real planning has to go. And we started our first use of telemedicine with behavioral health, like a lot of folks. It was easy, it was a quick win. And so we had the billing lady, the check-in person, one of the physicians, the nurse, everybody sat in a room, and we did a diagram, a flow chart of what had to change to accommodate a virtual visit versus a face-to-face. And so you had to think about it, not just from the high-end piece, but every little piece. When the patient calls and says, I have a telemedicine visit, and the lady who answers the phone has no idea what they're talking about, that's a fail point. So you have to take it from, like you were saying, the patient's perspective and the end-user perspective, and think it through all the little steps. And that was a painful 3 or 4 hour meeting, but then we got it done, and everybody knew exactly what to do. And they could refer to it. And we did some role-playing, and we tried it. And I find a lot of times once they just try it, get your hands, just please try it. I'll buy you lunch, just try it once. And then they're sold and they're hooked. And they realize that the technology is very simple, but it sounds very scary.
Yeah.
And so once they try it, they want to use it.
I read a very interesting article last week. I subscribed to Flipboard, for those of you that don't know what it is. It's a search engine for magazines and articles on the subjects that you like. And the title of the article caught my attention. It said, "The Death of Telemedicine." So naturally, I was curious. I read the article. And what the article was about is it is our job to remove the tele from telemedicine and to integrate it into daily health care. And the article was spot on, in my opinion. If we're successful, if we make it easy, if we really change outcomes, if we give everybody access, we will effectively kill the word telemedicine. And I see that as our goal.
If I can comment on that, one of my favorite meetings in the last couple of years, I'm not actually part of our connected care team, but we provide support to it. About 75 people, and they have a monthly meeting, and their medical director at a relatively recent meeting stood up and said, we need to think about what success looks like. And success is when you all have worked yourself out of a job. That this is just the way we do business. There isn't a thing called connected care. There is just the way we see patients.
That's great. I want to challenge you all to kind of focus some of the thoughts you just had, and thinking about members of the audience and the fact that they're trying to figure out how to be successful, or they might be thinking about buying into a platform. What are a couple of pieces of either tactical or strategic advice you would give members of the audience?
We've talked about a few already. I would say over and over again, think about the user experience first. What are you trying to achieve? What problems? Our physicians say, tell me what problem you're trying to solve first, and then work through that progression of, implement the technology when you know what you want it to do, not the other way around. And I'd say that the number one problem that we've run into is people come back from a show with, oh God, if we had that tool, the world would be different. And they try to shoehorn it in, and it won't work.
For us, it was really, I had to find a couple physician champions, because as an administrator, I can have all the great ideas in the world, but until they say it, then people really listen. So once I found a couple physicians, and we just did it as a pilot, and we had some real stories to tell, and we could start to quantify and qualify those stories, and then you start to build the case for why everybody should be looking at this. It really made a big difference. I mean, I think initially, my CEO was kind of, okay, you can go play, figure this out, and he wasn't really paying attention to it. Now suddenly, he's out there in front of our board talking about why this is such a valid, an important piece of what we're doing, and the ROI is so large, and how it's improving patient compliance. But really, for me, I kept hitting my head against the wall until I found a couple physicians to really be the champions, and they really began using it, and it wasn't a theory, it was now in practice. That was huge for us. And I talk with a lot of people who are just starting, telemedicine, and I said, don't focus on the technology. You're going to get calls from 20 different vendors, week in, week out. I get them all the time. I'm like, save your breath. Let me tell you what I'm doing. I don't need this, and that there's Cadillac versions with drop-down menus and all these different interfaces. All we wanted was a simple way to see patients virtually that was secure. My doctors were not ready to change and embed things. It's not embedded in our EMR. That scares my IT people to death. So it's over here, it's separate. But we just wanted a secure way to see people wherever they were that was, it was affordable for them. So we could send them a link on their cell phone, and the truck driver who's at the truck stop who just left the hospital from a heart attack, now I'm looking at him in his truck because I knew when he had to stop, and I'm talking to him about his care. That's the kind of stories we had to tell, and we began showing it. But to not focus on all the bells and whistles and don't get caught up in the latest toy, but what's the functionality you want to achieve? And you can do that in a very efficient way. It doesn't have to be a multi-million-dollar investment. I wish I had that, but hopefully it'll come one day. But you can start very small and very efficiently and not wait till you can do everything. Just start doing something.
Exactly. So from my perspective, I'm not a clinician, I'm not a physician. I work with many physicians. But the aha moment for me is when I learned to put myself in the patient's shoes and to understand the pains that they go through to get the health care they get. So a PTSD patient, for example, who's afraid to leave their own home. How do you get patient compliance with PTSD? Well, we give them an iPad and we start their visits on their terms. And then when they get well enough, we bring them into the institution for face-to-face visits. So that would be my biggest message. Put yourself in the patient's shoes. A rural patient, for example, has a primary care provider, and the primary care provider has very limited resources. So how do we augment those resources to help the provider, which in turn helps the patient?
Great. I mean, I think we've heard a couple of themes here. So, one being, think about what you really want the solution to do for you, but also be thinking about your customer. And your customer is your physician or your patient. And building a user experience that's engaging is important. Again, we're still not hearing about clunky technology or anything like that, which is really exciting. One of the things I want to ask you all to do is start thinking a little bit more future-minded. So imagine 5 years from now. Where might we be with, I'm going to call it virtual care rather than telemedicine, because I think the things that we'll be able to do will shift dramatically. Where might we be with virtual care, and how is that going to shift our ability to engage our patients? Steve?
I'll start with that. I think one of the most exciting things we've been working on at Mayo, we have been a destination medical center, tertiary specialty care for our entire existence. So we rely on a vast referral base. And as you mentioned, if you look at something even like total hip replacement, you're in and out very, very quickly. So we don't have that patient there very long. And it really, the time a hospitalized patient is with us is not a great time to communicate. They're highly medicated, they're in pain. So we really don't get a good opportunity to engage with them. We have started building out a Mayo Clinic Care Network where we're partnering with other organizations throughout the country. And the best outcomes in that program are that we are interacting with a local care provider about the care of their patient. And basically, we've set up a situation where there's a three-way win. The patient can stay at home, virtually or physically, get the care they need there. If they have a problem that's too big for that group to take care of, they can consult with us, and we are doing some of that virtually. Certainly, we're doing a lot of e-consults that way. But when they need the kinds of services we offer, we can get their referral in very quickly, and we can get them back home where they can get literally, seriously better post-discharge care in their hometown. So that's worked very well already, and I can see the virtual tools making those early connections and the follow-up care much, much easier, the engagement much more immediate. We're not quite there yet, but that's, I'd say, five years out, looking at how it will impact us. It will make us much more powerful as a highly specialized destination center, and having the patient stay at home for virtually the entire period of their care.
Well, my dream is that by then, the Florida legislature would have woken up. We will have great parity legislation in the state of Florida, because I keep hearing the challenges of reimbursement, and yes, people need to get paid for what they do. So hopefully that barrier will go away. It's not stopping telehealth from growing leaps and bounds in the state of Florida, but it is create a challenge so that we can really put the system back in towards healthcare system. Because right now it is so fragmented and so siloed, and we hand people referrals and prescriptions and we kick them to the next place, and there's no nice handoffs. And we've started doing that in some small aspect with other partners of doing this virtual nurse-to-nurse handoffs. So a child who has to go to Wolfson's or Shands sees that nurse, they meet that facility, they have that comfort level, and so they know where they're going. But I think really creating a system is going to save us all a tremendous amount of money, and that we go back to the black bag, the doctor going to where the patient is, rather than always expecting patients to come to us. I do a lot of work with our post-acute facilities, and the amount of money, even in my area, that we spend hauling people around in a 5-mile radius is astounding. That's money that could go to serve people who don't have insurance. That's money that could go to get people preventative health care that they desperately need. And so I think really it's going to take uniform embracing, I don't know if that's a word, this technology, but I think just stop punting people around and only worrying about our piece of the continuum and our piece of the puzzle, but having ownership and accountability to what each other does. And we're starting to see some of that. We do bundled pay with some of our hip and knee guys. That's why they were so willing to play with this technology. But in my area, we're still very fee for service. And so there's still that mentality, well, I do my piece and I need to get paid for it. I'm not worried about what happens over here or over here. But we have to collectively own that process and be accountable, and this technology is essential into making that happen. I hope it happens in 5 years. Maybe not. I'll be happy if we get a little further down the road. But I think, being able to get the care where you need it, when you need it, with the click of a button is that's essential. Oh, yay. You're my new friend.
So a little history before I complete my vision. In 2008, South Carolina was one of the states that chose not to extend Medicaid. And I don't know why they made that decision, but the decision was made. We're also a state with a lot of healthcare disparities, rural population, as I said many times. The legislator had a lot of foresight and was very gracious in their funding to the state. They funded us well enough that we could equip sites. So today we build networks and we equip primary care officers and we create the access that I'm so passionate about creating. But with today's buzzwords of innovation and integration, and I think Vidyo has really good product direction right now, especially with some of the new direction that we saw today that Mark shared with us. In 5 years, I see a patient anywhere in our state, regardless of who their provider is, picking up their phone, saying, I need a visit, this is why I need a visit, getting a response, and starting that initial communication with the healthcare system of their choice virtually. And then if there need to be brought into the healthcare system, then so be it. We're starting to see a little inkling of that today, starting with e-consults as an example. But in 5 years, I see it completely integrated into the larger healthcare systems and people choosing to get their healthcare in that manner.
Terrific. I'm going to challenge my panelists and all of you in the audience to think even bigger. Technologies exist today that are not widely spread through the healthcare ecosystem. One of the cool things about what I do is I get to spend a lot of time looking at the coolest technologies that are incubating. And just a couple of the things I've seen recently, one, virtual reality as a replacement for opioid pain management is in the process of getting FDA approval. So, the idea that you've got someone with chronic pain, recovering from surgery, we look at the opioid crisis in this country, VR as an actual technology that we can start to deploy sometime in the next 12 months in a prescriptive way also serves as a virtual engagement opportunity. So, kind of twofold opportunity there. Another great thing that I've seen actually in practice in some of our high-risk facilities is you can get a little sticker thermometer and send it home with a patient. It integrates into your analytics so that when that patient's temperature hits 99.4, it triggers an alert in the system, so you flag the patient for risk of septicemia before they would have picked up the phone and called you, probably before the patient realized that they were even not feeling great. So septicemia costs us millions and millions of dollars every year. The idea that we could intervene earlier when most cases, once they're diagnosed, actually require vent as a way to treat them, which is very high cost, is a huge opportunity. So think about virtual care not just as kind of your e-visits and engagement opportunities, but how does it serve as a connection point and a engagement layer for integrating a growing Internet of Things that enables us to better quantify, understand, and intervene at earlier stages of disease. So, yeah.
I was thinking when Michael was talking along those lines, I think looking down the road, all of us have an incredible smartphone in our pockets. Yeah. And the notion you're talking about the patient getting to decide when to make the connection. I want Siri to decide, hey, Steve, noticing an arrhythmia here. You might want to talk to your cardiologist.
Siri actually does do that today.
Yes, I know. And so look at a situation where your own device is monitoring you, and especially for chronic conditions, keeping in touch with your provider, kind of in the background, and not needing to raise your hand until something, until the device is saying, yeah, now it's time.
Yep. Absolutely.
The other thing that we haven't really talked about much is another arm of my job is regional development. And I spend a lot of time in our rural communities, and we have critical access hospitals and rural hospitals that are closing their doors, and they are starving and they are dying. And they have great nurses. They have dedicated people. They're in these little pockets, and we desperately need them. And I go in there, and they have empty beds, and I know we've got people that have been waiting 8 hours in the emergency room for a bed, and I think, there's got to be a way to do this better. And they can't afford to stay open. We're busting at the seams. So I think, again, many times we get a tremendous amount of patients transferred in every day, that if they just had that 10-minute look from a specialist or somebody to validate what their plan of care is, they can keep that patient, which is better for their business. It's better for us. It's better for the family member to stay close to their faith and their family and their friends. And so I really think being able to, like you were talking about access, increase that access locally where people are is so important. Because we have people in our counties that are 30 minutes away from us. They will not cross the Leon County line because that's going to the big city. They won't do it. I am not going to doctor in that city. I'm not driving in that traffic. I'm not going in there. And Tallahassee traffic is not like for most cities. But they just won't do it. And so if this gives them a way to access the care they need closer to home, just pulling in those pieces and really enabling a lot of those family practitioners to be that quarterback for care and pull in the other pieces when they need it, will reach a lot more people earlier in their continuum of their health and get the services where they need it.
Awesome. I want to give you all our last couple of minutes to ask some questions before we let these fabulous people get off the stage. In the front.
Yeah, so, and this is to you all as well as all the care providers in the room. So we talked about the design of the program and starting with the patient in mind. I'm curious, has anybody taken it to the next step to actually include the patients in design? Like get focus groups of patients together to provide early feedback and what it is that they have
Sure.
engaging in the program?
I'd like
So,
to take that.
just to repeat for the audience, the question is essentially, are any folks engaging patients in the design and implementation of these programs to get that stakeholder buy-in earlier? Michael?
So MUSC is currently constructing a new children's hospital, and we want it to be a state-of-the-art children's hospital. Lots of great specialists. From day one, we involved patients. We have one patient that has over 1,000 hours of community service to MUSC in the design of patient rooms and the interaction of the physicians. This lady, her name is Kelly Lloyd, delivered twin babies at 24 weeks and spent the next 80 days in a row in our children's hospital. And Kelly was a very successful businesswoman. She quit her job to consult with MUSC on how to treat patients better and be more patient-centric. And to this day, Kelly has over 1,000 hours of community service to our hospital and is on the board to design the new children's hospital and is involved with almost every single detail.
So that's a yes. And you guys have a packed day, and unfortunately we're out of time. I know myself and the speakers will be around for a bit today. If you have questions you want to chase us down for, we would love to talk to you. And I want to thank my esteemed colleagues for their time up here with me today.
Thank you.